Hello, everyone. Welcome to the Provider to Provider Consultation Line Tele-Echo. This is the Pediatric Mental Health Tele-Echo. And today we're going to talk about treating individuals with trichotillomania and excoriation disorders. I'm going to go through a few welcomes and introductions before we get started with our content. But my name is Jody Strother. I am the coordinator for the ECHO and the program manager for PPCL. This is going to be our agenda. We're going to do our best to stick to it. As if you've attended before, you know that time passes pretty quickly, especially when there's good discussion. So we will have brief introductions, move to our didactic presentation by Ashley Rush. And then we do not have a case presenter today, but I think the content will bring up some good questions and discussion, hopefully. But if you also have something that has nothing to do with the didactic, of course, you can bring up that too as a case, opportunity to discuss your case, any cases you might have. As always, everyone will receive a follow-up email with recommendations after we go through some clarifying questions, and then we will wrap up and have announcements for our next session. So again, briefly, I'm Jody Strother. I am a social worker, but I'm also the coordinator for PPCL. I'm going to briefly explain what PPCL is. In addition to offering educational opportunities like tele-echoes, we do a pediatric, which is this one, but we also do a perinatal one that's available for you to attend as well. We do webinars and other conference presentations, but we also do consultations, direct consultations. So if you have a case or a patient that you'd like to discuss with mental health professionals or possibly a connection to a psychiatrist, if you need assistance finding resources in your area for the family or the child you are working with, you can give us a call and we can help vet those and get that information back to you, where then you can share that with your client and family. So just a couple of the services that PPCL offers besides the tele-echo. Our website has a lot of information, so please look at that if you get a chance and you want to become more familiar with what we do. But I'm going to go ahead and turn it over to Dr. Christine Olivier, who is going to facilitate the rest of the session.
Hey, good afternoon, everybody. I'm Dr. Olivier. I am the psychiatrist on these sessions. I'm a child and adolescent psychiatrist over here in Lafayette, Louisiana, in private practice at Bloom Mental Wellness. You'll see on each of these sessions, I always do my spiel that we have a team of multidisciplinary providers representing different parts of mental health. I'm the psychiatrist representative. We also have a nurse practitioner / nursing representative, Ashley Hutchins. You want to introduce yourself?
Hi, everybody. I'm Ashley Hutchins. I'm a psychiatric nurse practitioner, and I also work at Bloom Mental Wellness in Lafayette.
Thanks, Ashley. And we have two social workers on our session today. Jody is one of them. She already introduced herself. And we also have Lena Raggett. Lena, you want to introduce yourself?
Sure. Hi, everybody. My name's Lena. I'm one of the mental health specialists for PPCL. And my main goal for PPCL is staffing the consultation line. So happy to be here.
Thank you. And we're going to go right into the session with Ashley Rush. She's going to talk about trichotillomania and excoriation disorders today. And so for this part of the session, we ask that you stay muted, but then we will open it up to questions in an interactive portion after the PowerPoint. So Ashley, whenever you're ready, please introduce yourself and you can go ahead and start your didactic.
Lafayette, I have a private practice where I just see clients virtually all over the state. I primarily treat OCD, but I also treat a lot of trichotillomania, excoriation disorders, phobias like emetophobia, and other things. So, yeah, you can go on to the next slide, please. Okay, so I know the title is kind of trichotillomania and excoriation disorders, but they're all kind of considered body-focused repetitive behaviors, or with the acronym BFRBs. And they also include any type of nail biting, cheek biting, lip biting, or any type of behavior that causes damage to the skin. So any kind of like physical harm and feels difficult to stop despite repeated attempts. So just for the purpose of making it easy in this presentation, I'll just use BFRBs to encompass all of those things. And they're all pretty much treated the same way. So yeah, just to make it easier. So yeah, about 3% of people have BFRBs. Again, it's a self-grooming action, hard to stop. People tend to try to stop, but are unable to. Next slide, please. So with BFRBs, they can occur in many different body areas. The most typical areas that I see are the face, the brows, eyelashes, as far as hair, skin picking, usually any place that like people can reach easily and can see is some of the more typical areas. But I always also want to make sure to ask about some other areas that maybe people aren't mentioning, right? So people typically aren't aware cheek biting can be a BFRB. They may pull hairs from their pubic area or pick skin there. Some people are even pulling from pets, right? Which is like sometimes a substitute for picking or pulling it themselves. So generally I ask about that as well. So BFRBs are typically coming from sensory needs or emotional regulation or any type of perceived flaw. So it could be there's an intense emotion, it feels satisfying to be able to like attack this area of my skin or my hair and like fix it. Or it can be soothing, a soothing experience. But they're never considered self-harm, right? So the intent is to regulate or to soothe. The intent is not to cause damage. So we want to make sure that that's clear. Very different purposes there. Okay, next slide. Okay. And body-focused repetitive behaviors typically come to light in adolescence. We tend to see them in the teenage years. There are more so observed in females. Obviously, many males get them too. I think definitely the clients that I see are mostly female, but I do have males, um, mostly pulling like beard hairs, eyebrow hairs, hairs on the top of their head, etc. So we want to look at when we're diagnosing a BFRB, we want to make sure it's not related to the effects of a substance. It's not due to another medical condition, and it's also not explained by some sort of hallucinations or something like that. Many people will use their fingers to pick or pull. Many people also use tools, so like a tweezer, a pen, something to like get at a certain area of the skin or the hair. And again, they're often driven by a need for sensory feedback or tension relief. So that can be like overstimulation or understimulation of the senses. Next slide. Okay. And here I wanted to kind of look at some conditions that can seem like they're similar, but they are very different. So these are definitely things that I'm looking for to rule out when I see clients. So the first is body dysmorphia. So with BFRBs, they will be sensory driven. Typically, they will reduce tension, and the goal is to fix an irregularity. So, like, let's say I have a hair that feels different, right? It feels like it needs to go. And then in body dysmorphia, there's an intense preoccupation with a perceived defect. So, like, maybe my hair feels like it's something that people are looking at and people are judging me for, and like I'm trying to fix that or camouflage that. So again, in BFRBs, we can camouflage areas of damage versus in body dysmorphia, we may camouflage areas that we perceive there's a defect. So like if I pull my hair on my head in a BFRB, I may wear a hat so people don't notice it. But in BDD, if I'm wearing a hat because of the concerns with my hair, it may be because like that's an intense flaw that I feel like I have. Okay, and then in BFRBs, they're often egosyntonic, like it feels satisfying to do the behavior, versus in BDD, it's extremely distressing. There's a lot of anxiety present. So yeah, again, BFRBs relieving, BDD is very much, shameful, a lot of anxiety present there, and typically a distorted self-image that isn't usually or always present in BFRBs. Next slide, please. And then OCD. Many people who come in for OCD will also have a BFRB. I forget the exact percentage, but it's something I'm always asking about if somebody's coming in for OCD. Like, I'm always going to ask if they experience like picking or pulling their skin or hair, because we also want to address that. Some people don't even realize it's a thing that other people are dealing with. So in BFRBs, people typically aren't having obsessions versus in OCD. They're extremely stressful, unwanted, intrusive thoughts. With BFRBs, the purpose of pulling the hair would be self-regulation, would be comfort, versus in OCD, if somebody would be pulling their hair, there would be an obsession present. It would be an attempt to neutralize a feared outcome. So an example there would be if somebody was pulling their hair and they had OCD, maybe they feel like if my hair doesn't look perfect, something bad may happen to my mom, or like some kind of connection to some feared outcome that isn't kind of logical, right? But there's that intense fear or distressing, unwanted thoughts. And it feels like, oh, I have to do these things because, in the example, I don't want anything to happen to my mom. And then also in BFRBs, people can be reluctant to stop because maybe it does feel really satisfying to pick at something and actually get it. Or maybe it does feel satisfying to like get that one weird hair. Yeah. Next slide. With BFRBs, there are two types. So we have a focused type and we have an unfocused type. So focused is, I'm aware I'm doing it. Maybe I'm even going to the mirror, or like I'm getting my implements that I'm, using like tweezers or something like that to pick at the skin or pull certain hairs. So I'm like fully aware that I'm doing the behavior. And maybe it's in response to feeling unsettled or bored or like anxious or something like that. And there's often a purposeful search for a specific irregularity in the skin or hair. So unfocused is typically automatic, unconscious. People don't realize they're doing it until maybe there's physical pain, or there's like a pile of hair, or maybe somebody tells them, stop doing that. So yes, and that mostly I see with my clients when they're doing unfocused BFRB behavior. Maybe they're driving, playing video games, looking at their phone, watching TV. So they're like doing something else that isn't maybe super stimulating. And then they notice eventually that they're doing the unfocused behavior. Next slide, please. So in therapy with clients, we have a couple of goals. The first is to build a ton of awareness around the behavior, around our emotions, around our thoughts, the other lifestyle factors, right? Like, are you moving your body? Are you eating healthy-ish foods? Are you drinking enough water? Like, how's your social life? So we're kind of looking at a bunch of different things. And so we want to, understand the connection between those things. We use some mindfulness, emotional regulation, distress tolerance. So like helping with the emotional side. We want to navigate negative emotions without kind of resorting to the BFRB. Like, okay, well, what else can we do if we are feeling upset or sad or mad or bored or lonely or whatever it is? And also implement healthier replacement behaviors. Next slide, please. Okay, so the therapy that I love and that I was trained in is called integrative behavioral therapy. So basically, this is a collection of evidence-based treatments, kind of all wrapped up into, to me, what feels like a more holistic therapy. And some of these little acronyms are kind of messed up, but you can kind of see it's supposed to say CBT. ACT, etc. I changed it later. But anyway, so CBT, right? We're restructuring our thoughts. We are looking at how our emotions and our thoughts affect our actions, how our feelings are related to that. We do a lot of acceptance commitment therapy. I love clarifying values with clients and kind of figuring out, well, we're doing these hard things in therapy, but why? Like, what is the reason that we would want to do these hard things? So we're working on some of that, working on, mindfulness, um, unhooking from unhelpful thoughts and feelings and sensations. There's a little bit of DBT. We go over typically like some of the tip skills, right? So if we are at a really aroused state, like how do we calm down? How do we soothe that? And then habit reversal training. So that's where we're looking at a competing response to something that's making it harder to do the behavior. Some examples of that could be like if I pull my hair in class, maybe I wear a baseball cap to class, right? That makes it harder because I can't get to the hair, right? I have other clients that really like, there's these fingertip gloves. So you can still use your phone, or you can still do other things, but it's not going to be satisfying to find a hair that feels different or an area of my skin that I typically pick. Like it's going to make it harder to do that with with those gloves on. And then we also have looking at the comb model, comprehensive behavioral treatment. We are kind of looking at the different parts of the BFRB. So looking at what comes right before it. So what are you feeling? What are you thinking? Who are you with? Looking at the actual behavior. So when we're looking at the behavior, we want to look at we call it the search. What is the search like? When I'm looking for that part of my skin that feels different or like bumpy, what am I feeling, thinking there, right? And when I'm also maybe picking at an area, what am I doing with that hair, that piece of skin? Like, am I looking at it? Am I disposing of it? Like, how am I feeling while I'm doing all of these things? That's kind of all things that we want to look at and build awareness of and be more mindful of. Okay, next slide. Okay, and then this is the first thing that I have clients do is keep this detailed log. So some of the things I just mentioned, again, building awareness, tracking frequency, understanding when, where, how am I feeling when I'm doing this. Many clients have an idea that they think they're aware of all of these things, but whenever they actually keep the log, it gives us a lot more information that we can work with. So I'm asking them to write down, where are you? Who are you with? What body position are you in? How are you feeling, thinking? How long did you pick or pull for? Why did you stop? Did you stop because it hurt? Did you stop because you felt bad about yourself? Did you stop because somebody was like, stop doing that? So all of that is really important information. Next slide. Okay, and then I kind of went over some of this stuff. So we are looking at, again, important things to notice. What, are you having any sensations? Like, do you feel a tingling or like an urge? Looking at some of those other things that we kept in the log. We're looking at certain targets. So like, are we gonna try to switch up our body positions when we're sitting on the couch? Or are we going to make the tweezers harder to get to? Those sorts of things. Are we going to substitute, if the behavior is due to like a sensory need, are we going to substitute it with something that is going to fill that need? Because we don't want to, let's say if I like the way it feels to like run my hands through my hair and I like finding the hair that feels different and that feels soothing, maybe I want to give you something that is similar to that, not just like some random fidget. So it's like substituting that sensory need for something that is similar. And there's tons of different like fidgety type things on Amazon. There's so many. There's also some great ones, and I give this resource at the end on the TLC Foundation's website. They have a bunch of lists of different, I think they call them fiddles for body focused repetitive behaviors. Let's see. And then we're looking at maintenance, which is basically like, how are you going to handle when you have a slip, right? So how are you going to handle if you do start pulling again, like building that toolkit to help people manage if they do slip, because typically BFRBs are across the lifespan. It's not something that like people are coming to therapy for and then they never do it again. It's like, how are you going to manage your relationship with your BFRB? Next slide, please. Okay. And then, yeah, I mentioned some of the stuff like we want to, make it harder to do the BFRB. We can like physically make it harder, wearing things, changing how I'm sitting. We can also have people like kind of do what's called urge surfing, maybe even making a closed fist for 60 to 90 seconds to ride out that urge. So you can't pick or pull if you have a closed fist. You can sit on your hands for 60 to 90 seconds. We're kind of like creating a moment where people can realize that they have another choice and kind of remember why that they don't want to pick or pull. Next slide. And then also, we always want to look at, are there any medical referrals that we want to make? So if there is an actual skin issue or a scalp issue, definitely referring to a dermatologist, because we want to get that taken care of, because maybe that would make it less likely for them to do the behavior. If somebody is swallowing hair, we definitely want to make that referral if they're experiencing issues, because that could cause a very serious blockage. So you want to be aware of that. And then a couple of supportive options. I have some clients that take, I think it's N-acetylcysteine, NAC, which is an over-the-counter supplement. It's been studied to be helpful. It helps some people with kind of the urges. I always tell clients to talk to their medical providers about that. Typically well tolerated. I think people take it like once or twice a day. People can also take medication from their psychiatrist or nurse practitioner for symptoms like anxiety. If they have ADHD, like we want to make sure they're medicated for those. And then there's also some non-medication options. Like there's a bracelet called the Keen bracelet that you can kind of train to, when you move a certain way, it'll buzz or it'll vibrate. So it'll kind of be a thing that will be able to bring your awareness to that movement and give you an option to choose not to do it or use another skill. There's a kind of a more intense bracelet. I don't know what it's called. I don't really recommend it, but I have clients who have bought it and they liked it because it kind of gives you like a shock, like a dog collar almost. And one of my clients really likes it because she said like it's definitely gonna like bring her attention. She's like, I can just override the buzz, but like if I'm getting like that shock, I'm not gonna continue doing it. So next slide. Okay, and then here, this is I really like bfrb.org. They are kind of transitioning over to be one with the International OCD Foundation. So that will be really cool. We'll have all our OCD and BFRB stuff in one place. I didn't put this here, but I definitely recommend the training by Marla Diebler and the book by her and Renee Reinhardt. So this is the book. It's called the BFRB Recovery Workbook. And they have a couple of trainings as well. The people that wrote this book, one is the more intensive training, one is a shorter one. And there's also a kid version that recently came out called Free to Be Me with My BFRB. So it's like a workbook for kids, but basically all of this stuff is exactly the same, just in, kid form. So yeah, that is it.
Thank you.